This last session features a good friend and colleague, Dr. Alan Matsumoto from Rheumatology Associates in the DC metro area. I've given him the difficult task of sort of summarizing all the new paradigms in RA treatment. We've had Eular guidelines this year, we've had ACR guidelines, a lot to tackle. Alan.
Thanks very much, Jack, and thanks to Artie and Jack for inviting me this morning and for including me with this distinguished faculty that they've assembled this morning. I'm Alan Matsumoto. I'm a rheumatologist in private practice with Arthritis and Rheumatism Associates outside of Washington, D.C. And as Jack mentioned, this morning I'm going to be reviewing highlights of the recent ACR and Eular guidelines for the treatment of rheumatoid arthritis. These are my disclosures. So I want to talk a little bit about this issue of recommendations or guidelines. These terms are often used interchangeably, but both ACR and Eular are very careful to caution that these are general recommendations and not strict guidelines for the treatment of rheumatoid arthritis. But I think it's useful just to look at the good and the bad of these guidelines. So the good is that it stimulates dialogue and critical assessments of best practices, which is what we're doing this morning. It provides a structured review of evidence to answer clinically relevant questions, and whether or not these questions are answered or not guides future research in these areas. And it also brings together diverse perspectives of physicians from various places in the world, and also including patient perspectives, which are often very useful in creating these guidelines. The bad, I think we all know about. They're often based on low-quality evidence. The recommendations, although they're supposed to be general recommendations, become commandments. They're often used inappropriately as quality measures to assess physicians. And as we all know, they're used inappropriately by third-party payers to limit access to therapy. And of course, it's also dreadful to have to read these guidelines and to listen to them at conferences. So that's really my challenge for this morning. So I'm going to be using the audience response system, and hopefully we'll get this up and running this morning. But I thought I'd ask a question about how we all use these guidelines. So how often do you consider ACR Eular guidelines when making clinical decisions about RA patients? Never, sometimes, frequently, always, or only when appealing insurance prior authorizations. So we've got something up here. I think a lot of the folks are going to be answering the insurance authorizations question. I think it hits home to all of us. Anything up here?
49% sometimes, 30% infrequently. Oh, there you go.
Okay. I'm having a hard time reading it from up here.
49% sometimes, 30% frequently, 8% always.
Wow. Much higher than I would have thought, actually. Okay. And moving ahead. So just some general overview of the ACR recommendations. They were last updated in 2015, so a fair amount of time ago. The project plan was published in 2018, and it's available on the ACR website, and I put that into the pre-read materials. The draft guidelines, as you know, were presented at the last ACR virtual meeting, which many of us attended. And the publication is due very shortly, and I was told by Roy this morning that they were officially approved in this past week. Their mission was to develop recommendations for the use of DMARDs and glucocorticoids, but specifically they were asked to look at specific patient populations, so DMARD naive versus DMARD prior usage patients, low versus high disease activity, and specific populations and comorbidities, and recommendations on tapering, and I'll address all of these in the subsequent slides. They came up with 44 recommendations, only 7 strong and 37 conditional. So I think it's also useful to look at how they use these recommendations and what their criteria were for the recommendations. Strong recommendations were recommendations in which they thought that there was confidence that the benefits of intervention far outweighed harms for most patients. And they also assumed that for most patients, there would be little variability in choice, that most patients would choose the course of action that was recommended. Conditional recommendations were recommendations in which there was uncertainty over the balance of risk and benefits, mostly because of the uncertainty due to low or sometimes very low quality of evidence. And they also assumed that patients might have differences in preference, that many patients would choose alternative therapy based on either patient preference, concerns about safety, or cost issues. The Eular recommendations that I'm going to refer to were published in 2020. It was a 2019 update. It was last updated in 2016, so they update more frequently. They used a task force of 47 individuals, which also included patients. And they approved 5 overarching principles, 12 recommendations, and only 9 of the 12 recommendations were unchanged since 2016. So obviously not a lot of changes for a fair amount of work. And they graded recommendations on level of evidence, level of agreement, and strength of recommendations. So again, I'm going to be using the audience response system to present some cases. And there are going to be 4 cases, which hopefully will highlight some of the more controversial aspects of the ACR and Eular guidelines. I want to stress that there is no right answer to this question, so I want you to all answer with truthfully about how you would manage these patients in your own practice. And this way you'll get a chance to look at what you do, and hopefully you'll get a chance to look at what other in the audience do, and also compare them to the ACR guidelines. So this is a very typical case of a 45-year-old woman with a 6-month history of new onset pain and swelling at the wrist, MCP, and PIP joints, 1 hour of morning stiffness, difficulty with dressing, so difficulty with ADLs. She denies any other medical problems. She has tender synovitis at the wrists, MCP, and PIP joints. SED rate was elevated. CRP and rheumatoid factor are positive. Routine blood studies are normal. So after discussion, you would elect to start the following regimen: methotrexate monotherapy, methotrexate plus a TNF, methotrexate plus Plaquenil, methotrexate plus a rapid taper of prednisone, or Plaquenil monotherapy. And of course, this also assumes that there are no insurance hurdles to deal with. So this is a very typical patient that we all see daily in our practice, new onset RA, but fairly severe disease. So Jack, what's the answer?
So with over 120 patients responding, people responding, 50% say D, methotrexate and taper prednisone. 42% say A, methotrexate monotherapy, and the rest is a smattering, with only 4% choosing methotrexate and TNF inhibitors.
Okay, so the key here is, remember, half of the group said not only methotrexate monotherapy, but methotrexate plus a prednisone taper. So what does the ACR say? So this is the group that they assessed as DMARD naive with moderate to high disease activity. Under the strong recommendations group, methotrexate monotherapy was preferred over other conventional synthetic DMARDs. And it was preferred over biologic monotherapy or targeted synthetic monotherapy. And it was also strongly recommended monotherapy over methotrexate plus a non-TNF or methotrexate plus a targeted synthetic DMARD. Conditional recommendations were methotrexate monotherapy over methotrexate plus another conventional synthetic DMARD or triple therapy, and conditionally recommended over methotrexate plus TNF or leflutamide. And just to round out their recommendations, if the patient had low disease activity, hydroxychloroquine was preferred over other conventional synthetic DMARDs. So the controversial aspect of this is glucocorticoids. So their strong recommendation, which is not surprising, is to avoid long-term glucocorticoid use. But what was interesting was, under the conditional recommendations, they recommended not to use short-term glucocorticoids. And this apparently was driven by patient concerns that it was very difficult to wean off of low-dose corticosteroids, and also some of the recent evidence that suggests that short-term glucocorticoids even at low doses early on in the course of disease, affects outcome and comorbidities later on in the course of the disease. So somewhat of a departure, and as shown by your audience response, a significant departure from what many of us do. So they went on to talk about methotrexate. None of these are surprising. These are all conditional recommendations, oral over sub-Q. If intolerant to methotrexate, splitting the dose, adding folic acid or increasing folic acid, switching to sub-Q. And if not on target on oral methotrexate, switching to sub-Q methotrexate. So things that we frequently do in our practices, so not very controversial at all. So the key here is that this is very different than the Eular recommendations for the management of rheumatoid arthritis, in which they clearly favor short-term glucocorticoids when either initiating or changing DMARD therapies. And I think we're all aware of those studies, mostly European, that showed the benefit to corticosteroids early on in the course of disease. So a very distinguishing difference between ACR and Eular on the issue of glucocorticoids. So case number 2, 62-year-old gentleman, followed by you for seropositive RA for 5 years. He has been in CDI remission on methotrexate 20 milligrams weekly and etanercept. 3-month history of increase in stiffness and pain in the wrists, slight swelling of the wrists on examination, does not complain of loss of function, CDI score modestly elevated at 10. After discussion, you decide to A, nothing, B, switch etanercept to abatacept, inject the wrists with steroids, stop etanercept and add hydroxychloroquine and sulfasalazine, triple therapy, switch oral methotrexate to sub-Q methotrexate. So again, a very common clinical scenario that we all see. Patient doing really well, kind of have a modest increase in the wrists. Do you really want to change things and rock the boat? Tell them to just suck it up and deal with it, deal with it. Artie's laughing about this. I think that's what he would choose. Jack, what do we got?
So the audience are a little bit split, about a third, a third, a third. A third saying, 35% saying inject the wrists with steroids, 27% saying observe, suck it up, 27% saying switch to oral methotrexate or sub-Q methotrexate.
Okay, right. I think those are all reasonable suggestions, and I think we would all say that those are reasonable choices. So does the ACR give us guidance on this? So this is the category that they call patients not at target. And all the recommendations are conditional, and I think that's evidenced by the fact that everyone kind of split on this topic. So if patients are on glucocorticoids, adding a DMARD to get them off of glucocorticoids certainly makes sense. If you're on DMARDs and not at target, add or switch to DMARD in combination with a burst of corticosteroids or a corticosteroid injection. On maximal methotrexate to add a biologic or targeted synthetic DMARD. And the key and the interesting part about this is that they clearly recommended this over triple therapy. And I think the people on the panel, as was described at the ACR meeting, were rather split on this, partly because, as we all know, of the studies that showed that triple therapy showed some equivalence to a biologic plus methotrexate in some of the earlier studies. But this was driven in part by the fact that triple therapy is not very well tolerated by many of our patients, as we all know. And certainly we've all voted with our feet, and triple therapy is not very used very often currently. And the other aspect of this that I think is somewhat controversial and departs from previous recommendations is if you're on a biologic or targeted synthetic DMARD, the recommendation now, at least the conditional recommendation, is to consider switching to an agent in a different class rather than using an agent in a similar class. So the other aspect of this is really what I find very, very fascinating is the differences in the recommendations of treat to target. So if you have not seen a biologic or targeted synthetic DMARD, the strong recommendation is continue to use treat to target over usual care. So these are patients in whom are DMARD naive, and we clearly still want to try to reach treat to target. The controversy is in the conditional recommendations. First is the second bullet point, which is that the initial treatment goal of low disease activity over remission. So they're clearly favoring low disease, and this is apparently a concept that many of us know, which is it's very difficult sometimes for patients to reach a remission. And particularly the patients were concerned that it was often psychologically very damaging when they were not able to reach the target of complete remission. But the other aspect of this, which is somewhat controversial, is that their conditional recommendation is that if you had failed one biologic or one targeted synthetic DMARD, that treat to target over usual care was only conditionally recommended, was not strongly recommended. And I think this dovetails nicely into the discussion that you just heard from Professor Birch, which is that oftentimes patients fail to reach remission not because of the disease activity, but because they fail to achieve our assessments of the disease activity. So many patients fail to reach remission because of pain or other confounding factors. Sometimes it's patient preference, not wanting to escalate therapy. But those patients, and we're all aware of them, patients with osteoarthritis or fibromyalgia or other painful confounders often are not able to reach remission or even low disease activity. And this is a concern that they raised in this conditional recommendation. So a little bit of a different, more nuanced approach to treat to target. And frankly, I welcome this because I think this is all what we do in practice in the so-called real world. So the Eular recommendations, I just outlined in red the changes in which they gave biologic DMARDs and targeted synthetic DMARDs even footing in terms of next choices. Other than that, there was not much change. And they still recommend remission and low disease activity in every patient. So a much more standard approach to this. Case number 3. A 59-year-old woman with seropositive RA has been seeing you for RA for the past 4 years. She has persistent joint pain and swelling on methotrexate monotherapy. 3 years ago, she was switched to abatacept in addition to methotrexate. She feels great and has been in CDI remission for the last 2 years. She's tolerating medicines, and as many of our patients present to us, Doc, I want to be off those medicines. I want to stop something. Don't I deserve to stop something? So you decide, A, the suck it up answer, which is you're doing great on methotrexate and abatacept. Why rock the boat? Rheumatoid arthritis is a chronic illness. Why risk a flare? B, taper abatacept by extending the dosing interval. Taper, and then with the goal of stopping abatacept completely, stop methotrexate, or initiate a taper of methotrexate. So distinguish between taper and stopping when you answer. Jack? Actually, here we go. Not yet. Sorry.
So most of the audience prefers initiating a taper of methotrexate at 65%. 3% say taper and stop the abatacept, and 18% to initiate taper of abatacept by extending the dose interval.
Okay, so I think you guys are cheating and have read the guidelines before I present it. The guideline committee would be very, very happy with this. Okay, so this is where these are all conditional recommendations, and I do think that the committee is obviously a little bit of two minds in this. On one hand, the conditional recommendation is continue everything, right? Continue current doses, don't risk a flare, particularly if there's no toxicity. But then they go on to say that if you are going to taper, and this might be driven by, again, patient preference, sometimes with cost issue, this is how our conditional recommendations of how you go about that. So they say dose reduction over a gradual discontinuation, right, as a conditional recommendation. Gradual discontinuation over abrupt stopping. I think that all makes sense for what we all do in practice. If you're on triple therapy, gradual discontinuation of sulfasalazine over hydroxychloroquine. Sulfasalazine seems to be the first drug that we all stop. And as you guys have all gotten correctly, they recommend gradual discontinuation of methotrexate over discontinuation of the biologic or targeted synthetic DMARD. And I think that's a recognition of the fact that you don't want to discontinue the drug that got you the improvement. That for the most of our patients, they're patients who have failed the methotrexate first, a biologic was added, so why do you want to kill the drug that basically resulted in improvement? Well, as you know, this is very different than the Eular recommendations in 2019. To be fair to Eular, they probably did not consider the recent studies that we've seen, notably the SEAM trial and Arctic Rewind that was presented over the last couple of meetings that shows that tapering a biologic results in significant flares. But their recommendations as of 2019 was to taper the biologic first. And they also are under, I think, more stringent concerns about cost in their patient population. Case number 4, a 58-year-old gentleman with seropositive rheumatoid arthritis. He has hypertension, type 2 diabetes, coronary artery disease. He's obese with a BMI of 36. He smokes. He's followed by pulmonary for reactive airways disease. He has nodules at both elbows. He has done well on methotrexate plus etanercept. Which of the following findings would cause you to discontinue methotrexate? So this is the classic comorbidity disaster that we frequently see in our offices and that we want to refer to other academic centers if we possibly can. So what are your choices? Why would you discontinue methotrexate? Nodules at the feet requiring surgical removal. The finding of non-alcoholic fatty liver disease found on ultrasound of the liver done for abdominal pain, done for not an assessment of liver, but just because someone was doing an ultrasound. Pulmonary fibrosis seen on CT scan of the lung, or none of the above. Okay, Jack, what do you got?
A very good question. 35%, really split, but the leading answer was none of the above, 35%, and evenly split between the rest.
Huh. All right. So this fits under the category of specific population discussions. And I think the fact that you were all split in these groups suggests that it was a very good thing that the ACR Guidelines Committee looked at these specific patient populations. Unfortunately, they're all conditional recommendations. So subcutaneous nodules in patients with high to moderate disease activity with methotrexate over other DMARDs. You only stop methotrexate if you think the nodules are progressive. So nodules in and of themselves are not reasons to not use methotrexate, and I think that's a very important issue. Pulmonary disease is also a very controversial specific population. And as you know, many of the pulmonologists believe that methotrexate accelerates ILD in the IR patient population. So oftentimes the recommendation to stop methotrexate comes from our pulmonologists. But when the committee looked at this information, they thought that the evidence that suggested that methotrexate increased ILD was not very robust, and that in patients with stable pulmonary disease and stable airway disease, that methotrexate conditionally could be continued over switching to other conventional synthetic DMARDs. Non-alcoholic fatty liver disease, as you know, is epidemic in our patient population. And in the setting of normal liver enzymes and function tests, no advanced fibrosis on ultrasound, they conditionally recommended that methotrexate could be continued in this patient population. So very nice to see that in their recommendations. In lymphoproliferative disorders, Rituxan is still conditionally recommended over other biologics. A recommendation on hepatitis B suggesting prophylactic treatment strongly recommended if you're hepatitis core positive and antigen negative. but frequently monitored if you're hepatitis B core antibody positive and antigen negative if you're starting a non-Rituxan biologic. So prophylactic therapy recommended only if you're starting Rituxan therapy. Heart failure is similar to the previous recommendations, is to be cautious with a TNF inhibitor in patients with class 3 or class 4 heart failure. And if you're on a TNF inhibitor and develop heart failure, the conditional recommendation is to switch to a non-TNF biologic, and certainly that's much easier with the current choices we have available to us. They made a recommendation about persistent hypogammaglobulinemia without infection on Rituxan at target. Many of us who have been giving Rituxan to patients over the years now are starting to see this, and their conditional recommendation is that Rituxan can be continued in those patients. And they made a recommendation about serious infection within 12 months. If you're not at target, to consider switching the DMARDs over glucocorticoid use, recognizing that glucocorticoids increase significantly the risk of serious infection. And if you're not at target on a conventional synthetic DMARD monotherapy, consider another conventional synthetic over starting a biologic if you have that option. So that's all I have this morning, and I guess we're going to open it up to questions. Thanks very much.